All right. So next we have another legacy site, different kind of site. So that you got Big Pete Center, been here since 2016, and now you have the MyMichigan Community Hospital out of Midland. This data will reflect their Midland practice, having just added Bay City. That'll be new, but MyMichigan's been with us since 2016. They have crushed it, and I feel like there's a lot of really good lessons here. So I'm gonna let you guys go for it.
Well, the first 2 years, I'm Andrea Millard. I'm the abstractor, and this is Dr. Sawaya. He's our physician champion. I'm hand-selected for this. Anyway, for 2016 and 2017, that's when we started those. That's our baseline. That's where we were at. And when we made the decision to work towards the chest X-ray goal, I was completely against it because I didn't think we could get anywhere down here to where we needed to be. We went down with this one.
Yeah. All right, so 2017 was kind of an interesting year for us because that was when, so first off, we in Midland were a 324 bed level 2 trauma center. We're kind of the central mothership for what's now a system that has 7 hospitals and 2 standalone emergency departments. So stuff gets kind of funneled to us. And when this was happening, it was kind of right when a lot of those extra hospitals were being brought on and there were shifts in the group. So a few of our docs kind of separated off to become a group that was staffing some of the outlying facilities. And we ended up actually getting an influx of 4 or 5 doctors from another facility kind of near us that was going through a staffing change. And what we found is this hospital they were coming from is 2 blocks away from kind of the big pediatric center in our area. So a lot of the kids ended up self-selecting there. So they didn't have a ton of experience seeing kids. And what we noticed is that chest X-ray utilization kind of bumped up at that point. So one of the reasons that we decided to focus on this was we saw that change. And also one of the local pediatricians, who happens to be my wife, Rachel, was like, why are all these guys ordering all these chest X-rays? So that's kind of why we decided to focus on that.
This is out in our little, we call it the fishbowl where our providers sit because there's a nice window so everybody can watch them in there. But on our cabinets up there, we do keep the bronchiolitis up there because that was one of our areas that we were getting the most chest X-rays in, even though we felt like there wasn't a lot of, I guess, data pushing them to do it. That was just one of the areas that we struggled in the most. And if you also look closely, you can see our Canadian head CT rule and our, is it P-curves over there or what is that one? Is that a posit pre-PE?
Yeah,
is that what that one is? I can't see it right now, but we do keep those all around in both of our ERs so that the providers can look at those, and I always put extras out.
Yeah, so that was one of the big things. So like with our head CT stuff, I could come to them with like, here's our validated rules for why you shouldn't be doing these things. But as far as decreasing the amount of X-rays, kind of the big pushes that we did from the ED side was, one, kind of bringing to them the medic kind of bronchiolitis. These are, reasons to think about a chest X-ray or maybe why you shouldn't. And then had our local pediatrician come in and kind of talk to them about indications why or why you wouldn't want to do that. I see the coordinating center nicely blacked out our call list and some slightly inappropriate memes that are also in the. Okay. And then, so the other thing that we did, and I think you'll see this as kind of a pattern for something that drives change, is we, along with our head CTs, did unblinded provider level performance. We were doing monthly sheets that were going out to all the docs, but now we do it quarterly. But it's a driver for type A people who nobody wants to be the low performer.
And I do separate all of our mid-levels also so that they can have their own specific data, because we did find on some of those that was where an outlier was. And if I had kept it in under our physician data, that would have been going to the wrong person. So we have been separating that out. And so this is like the pretty graph you saw in the beginning showed a nice steady decline. This is what I see every time I look at it, which is chaos. But one of the things I wanted to point out is that from 2016 until now, all of this up and downs has only been about it's been about 1,400 or so kids. So our volume is very, very small compared to what Kristen was just up here talking about. So, and then that month that was circled right there, that was just, we had 2 kids that fell into this. And one of them happened to get a chest x-ray and one didn't. So that took us up to the 50% usage, which it felt to me like there was no way we were going to get down because it was 1 kid that took us up to 50%. And I mean, there were other months that were like that too. It was just so obvious there that, you know, I felt like our little site couldn't make a difference.
And you can see COVID hit Central Michigan a little bit later than it did Southeast Michigan, so that's where those big chest x-ray spikes ended up coming from. So this is something that Andrea did as far as kind of reaching out to our community for kind of community engagement.
Yep, and some of you may remember from when we were doing the virtual meetings, I had talked a little bit about this. I started it with our urgent care because we were getting a whole lot of positive D-dimers sent over to us to then get the CT scan. So it took that option out of our hands as to whether we wanted to scan the person at all. While we were talking with them, we also talked about setting patient expectations for, you're going to go over to the emergency room, and then they were saying they might do some of these things, but those patients were taking it as, no, they told me you were going to do this scan, or you're going to x-ray my kid, or you're going to do all these other things that wasn't what was said, but what was heard by the family. We also branched out to the family practices because we get a lot of those residents come in our department, and we gave them all little badge buddies about the head CT and again, setting expectations. And then we've just kind of been keep branching out with this, and obviously he's got a tie-in with the pediatricians. So they were all happy to be on board with this also.
And that's something that we frequently will talk with so we have a family practice residency in Midland, and they rotate through us. And it's surprising to me how many of them have never heard of like the PERC rule or PCARN or things like that. So that's been a big kind of educational point for us when they rotate through with us as well.
And then they just wanted us to mention a little bit how we kind of do a team-based approach. Like, I'm very lucky, as I said, with having Zach here and also Dr. Greg. Every month I give them information on chest x-ray usage and our chest pain discharge rates, because those are, since we're a legacy site, you know, it's like 70% of our stuff. So we're trying to really work hard on those, and I wait and give them quarterly stuff on the other ones. But my boss is Deanna, and she is the system ED director. So she's over all of the EDs. And she is usually the one that sits down with me to work on our intervention templates for the year. And John, we have a great guy in IT who helps us handle all the hiccups there. And Catherine is new to that role. It was just within the last couple months, but the one that was in that role before had been doing CQIs for many years. So she was a great resource for me, and I'm sure Catherine will be too. But we all kind of communicate a lot, and it helps that we're a small site. So I can go out there and bug Zach when he's working and be like, hey, what do you think about this? So that's it for us.
I see you're coming through the windows of the fishbowl.
Yeah.